welcome to Put Your Heart Into It. This account are meant for educational purposes only and should not be used as a substitute for medical diagnoses or advice. If you have any clinical symptoms or medical questions, please consult a licensed healthcare provider.
American College of Cardiology, AHA, and ADA, and a bunch of other societies came up with updated lipid management guidelines. I think it was March 13th. And we have passed out a handout to everyone about the guidelines, which came out 2 weeks ago. And Dr. Pandya was very kind enough to summarize it and share with us. And thank you, Dr. Pandya. And here we go. So, why lipid management has changed? Because we have not been doing a good job in assessing the risk. So they came out with a new risk prevention score called Prevent ASCVD. Oh, sorry. Here you go. No financial disclosures. So that we're going to talk about why lipid management has changed, how do risk assessment with the Prevent ASCVD score, which is the new risk calculator, which is replacing the old risk calculator, the primary prevention framework, pharmacological escalation, special population, and some clinical cases we'll discuss. Why lipids matter? Because obviously ASCVD remains the leading cause of morbidity mortality. You know, all this atherogenic protein exposure is cumulative over a period of time. That is the one thing they're trying to get the message home. Consider this like diabetes, like a sugar, starts affecting the organs, the day you get diabetes. Same thing with the lipids. It starts affecting the day you get hyperlipidemia. And the primary care is the front line for prevention. And what's new? It is the Prevent ASCVD risk equation and earlier statin consideration for anybody with a risk of more than 3% 10-year risk. Return of the LDL and the non-HDL targets. If you remember, the 2018 was like 50% reduction. They took it, as a physician, it's hard to, what is 50, what's 40, because you have to go back, what his cholesterol was 10 years ago, whether it's 50% of 10 years ago, whether it's 50% of 5 years ago. And they took away that LDL of 70, 155 away. Now it's back, because it's easy for us to follow rather than just going through the history and trying to figure out what his original LDL was. Universal lipo-weight testing, and Dr. Harsh Patel is going to talk about that later, and expanded non-statin options. So this is a central illustration from the guidelines, and there are 4 things. Screen earlier. So screen at the age of 2 if there's a family history of premature ASCVD or severe hypercholesterolemia or familial hypercholesterolemia. Then comes age 9 to 11 to identify FH, that is familial hypercholesterolemia, and other lipid disorders. So after 9 to 11, then it jumps to 19. Screen lipids are for everyone at age 19. And then recheck at least every 5 years using the Prevent ASCVD score calculator. And I'm going to go over that calculator in a minute. Then aim for a lower LDL score. The lower LDL, so they're back to the numbers rather than the percentages. For ASCVD, less than 10% risk, it's 100 milli. If ASCVD is more than 10%, or FH diabetes or FACC score of more than 100, then it is less than 70. And with patients with clinical ASCVD, which are with multiple other comorbidities, it's 55. And so screen earlier, check regularly, and then aim for a lower LDL and treat longer. Check lipids every 4 to 12 weeks after starting off the initiation of the therapy, and the benefits increase with longer therapy. And so the new score calculator is the Prevent ASCVD, and it replaces the Framingham score or the pooled analysis score, and it applies to adults aged 30 to 79. It estimates 10 and 30-year ASCVD risk, improves calibration, and versus the old pooled cohort equation. And the risk categories are 4: less than 3%, 3 to 5%, 5 to 10%, and more than 10%. And in the pool cohort, it used to be like, I think, less than 5, 5 to 7.5, 7.5 to 10, 10 to 20, and more than 20. So now they have simplified it to less than 3, 3 to 5, 5 to 10, and more than 10%. And if everybody have their phones, they can scan this QR code. This will bring up to a website called ai-heart.org. And I'm going to get Dr. Bach to demonstrate that.
I had my labs this week.
So you're going to... So the first thing in that ASCVD, prevent ASCVD calculator is the age. You want to put in your age?
Age 50.
You want to put it in?
Sure.
Okay. And then you put your, so the other thing is, this is also sex specific. It includes both males and obviously females. So you put in your sex, then about your total cholesterol.
Total cholesterol 182.
HDL.
65.
And then you, and the other thing they have added is, actually the blood pressure was there before, so your systolic blood pressure.
120.
And EG and GFR?
80.
So the GFR has been added to this risk calculator. And what's your score?
The 10-year score is less than is 1.4%. The 30-year score is 8.8%.
So that puts you at what category?
Low.
Low risk. Okay. So, I have, if you can use this tool, I have it open on my laptop, and whenever I go to my patient's room now, I just plug in these numbers, and you get the score, the 10-year score and a 30-year score. And it is a very useful tool because if you play with it, it also goes down into, the risk enhancers, and I'm going to talk about that. Also, we'll talks about the primary prevention, what the recommendations are. So. And you can even upload your EHR note into this, and it will, tell what the risk is and what the recommendations are. So it goes over, all the guidelines we're going to talk about today. And so the main premises of the cardiovascular risk assessment is CPR. CPR, calculate the risk prediction equation, that is the prevent equation. Then personalize the risk factors, that is the risk enhancing factors. I'm going to go over that. And thirdly is reclassify using coronary calcium score. So calculate, personalize with risk enhancing factors, and reclassify using the calcium score. So this is the CPR. First is the calculate the score, then it divides into 4 categories. That is the low risk, that's less than 3% like Dr. Park. Borderline risk, I calculated mine, I was the borderline 3 to 5%. Then the intermediate risk is 5 to 10, and the high risk is more than 10. Then you personalize based on the, further, if the low risk, you don't need to do anything else. Basically just lifestyle modification. If it is a borderline risk, 3 to 5%, then you use the risk enhancers. And I'm going to jump the slide real quick, and I'm going to go over the risk enhancers real quick. And the risk enhancers, which you can use in the patients, which majority of our patients will be probably between 3 and 5%, is if they have a history of premature ASCVD, that is onset of age less than 55 for men, 65 for women, you know that already, higher risk ancestry. They've added South Asian population as a high risk, and also the Filipino as a high risk category. High polygenic scores is a DNA, is a test. You can get the polygenic scores. We haven't started doing it yet. I don't know if anybody else is doing it here. If they have a chronic inflammatory disease like lupus or rheumatoid, if their lipo is above 125 nanomoles or 50 milligrams. The problem with lipo nowadays is, what units, because you get the results from different labs use different units. Somebody used nanomoles, somebody used milligram. So just be careful of that. If your CRP is above 2 on more than one occasion, so if you have at least 2 times or higher, if it's CRP, that puts you at a higher risk. Triglycerides persistently above 175. Non-fasting and fasting above 150. Cardiac, CKM is cardio, kidney, metabolic syndrome. And if the LDL is persistently high above 160 to 189, ApoB has also been added if it's above 120. Reproductive risk markers came in for the first time: premature menopause, preeclampsia, gestational diabetes, gestational hypertension, and preterm. So if you have any of those risk enhancers, you actually can not prescribe. You can prescribe if the patient wants to take it or not, but at least you can tell the patient that because of the risk enhancers, even your risk is 3 to 5%, lipid lowering may be helpful along with the lifestyle modification. Then the intermediate risk is 5 to 10. Obviously, discuss the risk and the therapy options. And if the patient is reluctant to take lipid, then you can take the help of the calcium score to help guide the therapy. And the high risk they need to be on lipid lowering therapy. Usually high risk, they will not require calcium score because they're already high risk, but sometimes of the patients still you have to get it done to convince them. This risk enhancer we talked about. And the role of coronary artery calcium, useful when statin decision is uncertain. If you have a CAC score of 0, it may allow deferral in select patients. CAC score of 100 supports statin initiation for sure. Above 300, they have added this for the first time, that should be treated as secondary prevention, because it should be assumed that the patient already has significant coronary artery disease, so it's secondary prevention rather than primary prevention. If you have to take, take the picture of this slide, because this helps to manage the subclinical atherosclerosis, so based on the calcium score. If the score is 1 to 99, not 9, then start moderate intensity statin with the LDL target of less than 100. If the score is 100 to 299, then obviously start an LDL lowering therapy, and again the target now is shifted down to less than 70. So if your score is 1 to 100, target is LDL target less than 100. If the score is 100 to 300 or 299, the target is down to less than 70. If it's severe, between 300 and 999, then again the target is less than 70, and then you add an optional ApoB, goal of less than 70. And they even recommend going down to 55. I have a hard time getting my patients to take a statin, forget about getting tightening up their dose, but the recommendation is that you can even go up to 55. So the CAC score 300 to 399, again less than 70, but you can take help of ApoB to intensify the therapy. Above 1,000, the goal now is less than 55, and optional ApoB goal of less than 55. And the one more thing they have added is that if you order CAT scans all the time for, say, chest, and you get a incidental finding of coronary artery calcification, so the recommendation is now that should be treated as that you have calcified arteries based. You don't even have to go for a calcium score, but to quantify you can. And if you have a mild calcification, the goal is less than 100, and if it is a moderate to severe calcification on a CT scan, then the goal is less than 70. And so this is just summarizing the goals: less than 3% lifestyle therapy, 3 to 5, moderate intensity, 5 to 10% risk, moderate to high, more than 10 high risk intensity statin, and addition of non-statins. This is if you want to take a second, 2 pictures only, this is the second picture I would recommend you to take. This is the primary prevention guideline. And these are the patients who don't have any atherosclerotic heart disease. And adults between 30 to 79, you do the health behavior counseling, calculate the 10-year risk using the ASCVD risk calculator, and then you divide them into 4 categories. Low risk, really, you don't need to do anything except, until unless their LDL is above 160. If their LDL is above 160 in a low risk, you can discuss if they're ready to take a statin, and goal is less than 100. If the LDL is less than 160 in a low risk individual, no need for any therapy except for lifestyle changes. Borderline risk, that is 3 to 5%. That if they decide, if the patient agrees to start a statin, then the goal is less than 100. If they don't want a statin, then go for the calcium score. And we discussed about the calcium score, how to treat that. The intermediate risk, which is 5 to 10%, again, the recommendation is to start a statin with a goal of less than 100. If they don't want to take a statin, then get a calcium score and base your treatment based on the calcium score. If the calcium score is 0, lifestyle. If calcium score is above, not 0, even like 10, then you can start lipid lowering therapy. High risk, high intensity statin, goal is less than 70. And if the LDL goals are not met, then statins can be added, like Repatha and bempedoic acid. And Mediterranean DASH diet, limited saturated fats, and physical activity, as Dr. Engels talked about, 150 minutes per week. And weight loss improves triglycerides and LDL. Dietary supplements, they are not recommending. All the patients come up with red yeast rice, and actually I've been telling them to take those who don't want to take statin, but they don't recommend any dietary supplements like over-the-counter to reduce lipids. The foundation is still the statin. If the moderate intensity is atorvastatin or rosuvastatin, I typically use rosuvastatin 10 milligrams. High intensity is rosuvastatin 20 to 40. And percentage LDL guidelines, they still is part of the therapy too, but I usually go by the targets. It's easy for me to explain to the patient and myself. Non-statin therapies, they recommend ZT as the first add-on, PCSK9 at high and very high risk patients. Intolerance, they can take bempedoic acid, I can never say it right, and Leqvio twice daily dosing for other patients. They came up with the hypertriglyceridemia guidelines too. These are managing the adults with hypertriglyceridemia. Again, they divided into 4 categories. ASCVD with hypertriglyceridemia, diabetes, age more than 40, without ASCVD, and the severe hypertriglyceridemia. Their recommendation is to calculate their ASCVD score, all right, and look for any secondary causes for hypertriglyceridemia. Initial therapy still based on their ASCVD should be statin and lifestyle, and optimize the glycemic control rather than jumping to any medications to treat triglycerides. And even after treating their, optimizing their diabetic control, and if optimizing the LDL, and if they are still having triglycerides above 200 or 150, then you can treat them with the triglyceride medication, triglyceride lowering medications. So managing the triglycerides above 500. Identify and manage the cause. If the persistent and after checking their CVD score, you can divide them into, if the risk is high, which is typically anything above 5% or definitely above 10%, then you can add ApoB as also a secondary risk enhancer, and add fibric therapy or omega-3 fatty acids. And if their triglycerides above 1,000, then obviously you're going to start them on the fibric acid derivatives of the omega-3 fatty acids, and add. There's a new drug out, olezarsen, for triglycerides above 1,000. The next one is adults with diabetes without ASCVD. If the young diabetics, 20 to 39, if their risk is less than 3%, which and you look for a risk enhancer in those patients. And the risk enhancers for diabetics, they recommend obviously, if you have retinopathy, neuropathy, PAD, or CKD, or if you have the albumin in the urine, then consider starting moderate intensity statin. And for the age above, again, 30, because the prevent ASCVD score is applicable only to patients age above 30, start moderate intensity statin if their risk is above 3%. 40 to 75, they recommend starting lipid-lowering therapy based on the ASCVD score. And so, in a nutshell, that was a busy slide. So, age 40 to 75, at least moderate intensity statin. If there are multiple risk factors, then high intensity statin. LDL goals are less than 100 in the low to intermediate risk, and high risk is less than 70. And if the triglycerides are elevated, adding ICE. Well, sorry. And lipoprotein A, Dr. Patel is going to talk about high risk is above 50, and intensify LDL. There's a whole 20-minute lecture on this. Coming up, monitoring and follow-up, we talked about earlier, recheck 4 to 12 weeks after initiation, and then every 6 to 12 months. And take home is earlier intervention reduces lifetime ASCVD risk. Use the Prevent ASCVD calculator to calculate the risk. LDL targets, 55, 70, and 100, and primary care drives the prevention. So we're gonna use this case and use the ASCVD calculator, the Prevent ASCVD calculator. 45-year-old male. Total cholesterol 220, LDL 140, HDL 37, GFR 60. Under the risk enhancers, family history of premature ASCVD, and then you can. What's the risk?
Still low, 0.3%.
Wow.
55 male, 220, 1 total IC. I put the HDL 140, so it went up. It goes up right away with 1.8%.
Still low risk, right? Now we put a calcium score of 40. So based on the risk score, it is low 3%. But now you're going to personalize and reclassify. You personalize so that you CPR, calculate the risk, personalize with the risk enhancer of family history. Anytime there's a risk enhancer, it increases your risk. They haven't quantified the risk, but they say that it goes up another level. And with a calcium score of 40, so if you just went by the score, you would have said patient does not need any treatment, right? The score is what was this risk? 1.3%.
1.8.
1.8%.
The calcium score makes it go up quite a bit.
Right. So
over 5%.
And what does your calculation say now? What the treatment? Because this calculator is amazing. This tells you what to do with the patient.
It's giving you statin guidance of low to moderate intensity statin.
So you want to try to get the LDL goal less than 100 in this patient.
Correct.
So if the patient agrees, will you start him on a statin?
Gives you recommendations for monitoring LDL goal. So it's very helpful for patients and for the provider.
So yeah, this is the tool I use from ai-heart.org, and it's a beautiful tool. They're also coming with an app. You can download. The app is not ready yet, but I have it on my laptop and I use it when I discuss with the patient to calculate the risk. Alrighty, thank you everyone.
Thanks for listening. Tune in next time for another cardiology-focused episode.